Welcome to the Tumor Clinic. My name is Daniel Helbling. I'm a medical oncologist here at the Onkozentrum in Zurich. Next to me is Dr. Christoph Renner. He is a specialist in hemato-oncology. And today I'd like to know from him, what is a multiple myeloma? That's kind of a strange word. What's that really?
Yeah, it is an old world. It is probably now more than 150 years ago that it was first described. It is a disease which usually starts in the bone marrow and which then leads to a destruction of the bone, which then can lead to fractures.
Okay. The bone marrow is everywhere, is that correct?
Bone marrow is everywhere, so whenever you have a bone, the inner part usually is filled up by the bone marrow, and if you have these cells of the immune system, which are called plasma cells, and they are the cells of origin for the multiple myeloma, if they develop into a tumor, they start to dividing rapidly, and then they lead to bone destruction at the place where they sit. And so that can happen at almost every bone in the body.
All right, so they are sitting in there and they are kind of growing and they cause fractures because they destruct the stability of the bone.
Yeah.
And what other symptoms do the patients have?
So beside that, the normal function of plasma cells is to produce so-called immunoglobulins. These are proteins which we need in our body to protect ourselves from infections. Now, if it's a tumor developing out of these plasma cells, they constantly produce these proteins. So we might have an overload of these proteins in the body, and then they circulate with the blood. They can, by the blood vessels, are transported into the kidney, into the lungs, into the heart, in the intestine.
They cause there some damage.
And then they cause damage because they can we have this kind of disease where we call them deposition disease. So you have an overload in the tissue with this protein, and if you have an overload, for instance, in the kidney, you have kidney damage.
Okay. Which organs are really at risk?
So the organs at risk are the kidneys, because that is a very important organ for us to get rid of fluid, and the heart. These are the two organs where we look very carefully at any patient with multiple myeloma to check if there is damage at these organs. And beside that, the bone.
The nerves also a little bit, I think.
And then we have the nerves, where we have, if we have deposition of the protein there, we have dysesthesia, hyperesthesia, any tickling, sometimes patients report about numbness. These are the symptoms which can be caused when a nerve is damaged.
So the sensibility has changed in a way, so that what the patient feels.
Yeah.
Okay. All right. So we have these symptoms, and once you have diagnosed it, how do you diagnose it actually?
Well, because these plasma cells produce this protein which is circulating in the blood, you can, in most cases, really do it by just taking a blood sample. But we still recommend to do a bone marrow biopsy to look really at the place in the bone marrow where these cells usually reside and look if they are increased in numbers, if they look different by morphology. And we recommend to do a bone scan. Nowadays, I would say most people do that by a CT scan, which can be done very quickly, and you can look at all the bones, all the major bones in the body. And if you have these three analysis done, you can actually make the diagnosis of multiple myeloma or not. And with a bone marrow biopsy, you have the option to do what we call cytogenetics, so you can look at the molecular profile of this plasma cells.
So how the myeloma works.
Yes, and by understanding if there is any gene mutation, alteration, mutation, you can make a judgment about potential not diagnosis, but about the risk category the patient belongs in. We have some gene mutations where we say that is what we call a high risk. So that is a patient where we usually see the disease progressing more rapidly. And then we have other gene mutations where the patient usually has a favorable course of disease, very prolonged time. And then if we have these patients, we recommend if it's a rapidly progressing one, a more intense treatment, if it's a slowly progressing, sometimes even watch and wait, or a mild treatment.
Okay. Regarding the bone scan, you just said these bones can fracture. Can you actually see that a fracture might come or might arise in a certain place?
Yes. So the radiologist, especially if you do CT scans, can very precisely look at these what we call osteolytic lesions and then comment about the stability of that lesion.
Okay, osteolytic means that the bone is actually eroded. It's taken away and the stability is lost.
Yes.
Yeah. Okay. So you can see that. Probably important for the patient to know whether he has some of these, because he shouldn't carry heavy things or do certain things, I guess.
Yes. So if any bone pain or if any pain occurs and doesn't go away after 7-10 days, that is always a sign which is leading or should lead to a more detailed analysis by CT scan, and then one should look if this area is damaged by osteolytic lesions and if there is any fracture. And yes, if you have osteolytic lesions, you should not carry heavy weights. You should not exercise too much, but you should, on the other hand, not stop doing physical exercise, but you should find a balance. But your doctor will then, I think, give you a recommendation about what you should do and what you shouldn't.
Okay. You just mentioned before that one can risk stratify the patient, so you can say what kind of risk do they have, what kind of aggressiveness do they have in their myeloma. Can you just briefly outline how the treatments work nowadays? What are the possibilities of treatments?
So if it's what we call a symptomatic multiple myeloma, and that is the multiple myeloma where we say is in need of treatment, then we still divide the patients into the ones where we say they can or they are fit enough for a high-dose chemotherapy with autologous stem cell transplant.
There's a separate video regarding this. I will do that. Well, I don't know whether it's already done, but we'll do it.
Okay, which is an intense kind of treatment. So usually patients under the age of 65 or 70 will tolerate that. And then we have, on the other hand, the patients, either elderly ones or those ones where you cannot administer high-dose chemotherapy, and these are the ones where you give a milder treatment for a longer period of time, mostly to control the disease.
How long?
Sometimes some of the protocols are running for up to 18 months, and you still have patients who are on continuous treatment for up to 2 years, 2.5 years. If they respond and you control the disease and the quality of life, which is very important in these patients, is good, you try to treat for really long time to control the disease. For the younger ones, you try to, what we call in the first phase, do an induction treatment. So you try to reduce the load of the disease. Then you should collect the stem cells to perform a high-dose chemotherapy with autologous stem cell transplant. So you try to consolidate the good response you have after induction. And then your doctor might talk to you about what we call maintenance. So when you have reduced and consolidated the disease, should you give a treatment to keep it at that hopefully very low level, which is a maintenance treatment, for instance, for 2 years.
Okay. I see. So that's quite, first you reduce the disease, then you give a real hammer on it, that it really is knocked down completely, and then you even do some kind of permanent treatment that it never will come back. So that's kind of the principle, I guess.
Yes. And unfortunately, you cannot guarantee that it will never come back. But what we can nowadays, by doing that and using what we call new drugs, you can really improve. In the past, it was the overall survival for advanced multiple myeloma was 3 to 5 years. And now we talk about 8 to 10 years.
Okay, so it's very different.
So it is really different, and really the presence and accessibility to new drugs has really changed the game in multiple myeloma treatment.
I think it's important to say that the prognosis is really different for each patient, and it has to be assessed really based on their character, on the disease characteristics. And we do these videos, but I think we have to say that there's so much information you just need to get from the doctor. You need to see because there's so much detail in everything. But just to give this overview, I think it's valuable. And I see that the treatment do change a lot nowadays, and that you're really up to give the newest and best possible treatment options. And perhaps you can give us a small summary regarding the disease and how it is treated. And then I think patients would come and see you because it's too complex to give all the information in one short video.
Yes, I think it's a very complex disease, and as you said, it needs to be diagnosed in a precise way because every patient is different. Then you need to talk to the patient about what are her expectations, what are possible comorbidities, limiting treatment, and then you have to decide on an individual treatment plan, which is certainly guided by our current knowledge and from the information we have from large trials. But as you said, every patient is different. And then what we do is a kind of 4 months, as we just said, induction treatment, followed by a 2 months high-dose chemotherapy with autologous. Then probably another kind of what we call additional consolidation for 2 months. And then in some cases a maintenance for at least 2 years. So you see, it is a kind of very long treatment, but quality of life is usually very good because the response to the new drugs is rapid and it has usually a nice sustainability. So patients have a normal life, they can usually go back to work, but are still under treatment.
Okay.
Only for the phase of this very intense high-dose chemotherapy with autologous. There, what I say, we take them out of normal life for 2 to 3 months, but usually they recover well and then go back to normal life.
Okay. I think it's great to feel your fascination for the disease. In general, for hemato-oncology, it's also great that you joined our team, and I'm also glad to send you all my patients regarding this disease. So thank you very much for this interview.
You're welcome.
Bye-bye.